morning, everyone. Welcome to Pediatric Grand Rounds. If you are nearby, please join us in the Mill Mountain Conference Room at the Tanglewood Center. And thank you for all of those joining online. Today's speaker is Dr. Michael Jeremiah, Professor of Family Medicine at the Virginia Tech Carilion School of Medicine and the Chair of the Department of Family and Community Medicine. He serves as the Senior Medical Director of Population Health for Carilion Clinic and is the President of their ACO, Doctors Connected. He received his BS from Duke University, his MD from the University of Florida School of Medicine, residency training in family medicine at Carolina's Medical Center, and faculty development fellowship at Carolina's Medical Center and the University of North Carolina at Chapel Hill. He joined Carilion Clinic in 1995 and has served as a medical director for the family medicine residency program for 12 years. He served on the faculty of the AAFP Chief Residency Leadership Program for 10 years and served on the executive committee of the I3 Population Health Collaborative, a combined effort of 25 residency programs from Virginia, North, and South Carolina to show value-based care outcomes. He co-chaired the VTCSOM's Task Force on Diversity, Equity, and Inclusion and serves as the co-chair for the Carilion Clinic Addiction Task Force. Please join me in welcoming Dr. Michael Jeremiah.
It's actually great to be back with you. It has been now at least 3 years. It was pre-pandemic that I last was able to come share a little bit about population health, and a lot's changed in 3 years, but I'm glad to be back here and to give you an update and look forward to any questions that you may have. So, there we go. No disclosures, no conflicts of interest to let you know about. 3 objectives that we want to be able to cover this morning. First is to describe key components of what is value-based care, and I don't assume that anybody knows anything about it. I know some of you may have heard some of this before, but some of this may be brand new to the rest of you. We also want to discuss ways specifically that pediatricians can align with and enhance and even lead some of the efforts to deliver this value, not only to your own populations, but to other populations across the system. And then we want to define what are some of the next steps for Carilion Clinic's journey towards value, and we'll explain a little bit more about what that means. So value-based care, it's, I think, helpful to start with the definition. So what does it mean? What does value mean? And a simple definition that keeps kind of proving true means value is outcomes, whatever you're seeking in terms of outcomes. It could be control of your diabetes, or it could be control of a population with asthma, over whatever it takes to achieve that. So any of the costs, that could be time, that could be resources, that could be people, that could be actual new money that you're putting into that. That's going to be the value. And you really have to look at both sides of that equation to be able to decide what you want to do, how you can do it, and how you can sustain that. And a little more history we're going to start with. So this is one of my heroes. This is a pediatrician, Dr. Don Berwick. Don Berwick had an experience of his own family that shaped the rest of his career and really led him to become a prominent voice across the country around value. His father was suffering from heart disease and had a heart attack, was getting ready for open heart surgery. And being the good son that Don is, he accompanied his father into the hospital system and wanted to be able to help, navigate and answer questions and make sure he was getting good care. He was appalled by not only the bedside manner of a lot of the people that he interacted with, and also some of the technical jargon and the poor explanations and the downright mistakes that he saw being made on a regular basis. And he came away from that experience after having helped his father get through it to develop a whole new approach, and he developed an institute. It's called the Institute for Healthcare Improvement. And it has proven to be a real beacon of kind of great ideas and think tank around what can we do, what should we be doing. And they coined an idea that has continued to resonate called the triple aim, meaning that we can't aim for just one thing. We fall short of what we're really trying to do as a health profession and as physicians if we're only aiming for one aspect of this. And the first is patient experience. So our patients have to have an experience that meets their needs, that really is geared towards what they're hoping to achieve out of healthcare. One example of that would be, can they even get in? Can they get into access to our specialists or to our primary care physicians? Second is quality. We have to be relentless about providing the best outcomes and the best quality. And then the third is we have to try to control cost. Not necessarily always lowering cost, but the cost of healthcare continued to outpace, over the long term, inflation every single year, every single decade. And we have to do things to try to control that, try to flatten that curve. The other thing historically that was a bit of a game changer was actually from Congress. I know that may sound like an oxymoron, that Congress actually did something that changed something towards value, but it was in 2015 that they passed something called the Medicare Access and CHIP Reauthorization Act. Before that time, they had always said, well, we need to control health costs, we need to do that, we really need to do something this time. And the way they did that was to have something called the Sustainable Growth Rate Act. And that was back in 1997. Every time we got up to the date of when something would kick in from SGR, it was going to be something like a 10 or 15 or even a 20% reduction in payments to physicians and hospitals. And every time we got close to it, there would be a lot of screaming saying, no, that will decimate our ability to continue to provide care for those populations. And they successfully lobby to kick the can down the road. So they would delay it, and they would delay it. And so it really didn't change anything. It was on paper, but it wasn't really doing anything. So in 2015, what they did is take a different approach. They said, okay, we're not going to cut the amounts we're paying, but we are going to start to limit in other ways. We're going to start measuring your quality outcomes. And if you don't provide the outcomes, you're going to get less money or less of the new money than those that are providing outcomes. And they started grading. And so that was a real different change and different approach. It was passed overwhelmingly in the House, 392 to 37, and in the Senate by 92 to 8. And it has continued to influence how this has rolled out in terms of how insurance companies are paying for the care that you're delivering. And this is a very busy slide, but it shows you some of the timeline of how this has rolled out. And you can see where we are in 2022, but as this was going from 2015, there was a little bit of a changeover period, and then it gravitated towards one of the two paths on the bottom. One is called merit-based incentive payment system, and that's where if you are an individual practice, a group, and you decide to be able to take that path, the only way to get increases year over year is to score a certain amount on your quality outcomes. The other alternative pathway, which is the bottom one, is if you're participating in a program that has some of those things built into that. That's the path we chose. We chose to be able to do that, to be able to be an ACO and to be able to participate in that program, but there's a lot of check boxes you have to do to stay in that type of program. Another historical change for us that many of you are aware of was the change in Medicaid expansion for Virginia and across the country. The Affordable Care Act in 2013, it allowed expansion across any of the states that were willing to adopt that. And you can see the uninsured rates here running up around 17%, then we're able to drop down to about 10% after the initiation of this aspect across the country. Virginia took a bit longer. They were debating about the pros and cons of that, and then that was enacted in 2019. And it has drastically expanded the access for those who did not have that eligibility before. This is a little bit of the details. Before 2019, you had any childless adults who were not eligible in Virginia. You had to be those with children or those with a disability were the only ones eligible. And it also changed the thresholds in terms of income and therefore, again, expanded access across the Commonwealth. These are the states that are, although those in blue that have expanded and those that are in orange have not yet adopted that. But it has made a big change across the country. And again, for us, we've seen that play out across our state. So this is our Commonwealth again, and just show you this because one of the challenges we have in this part of Virginia is we are very spread out. So we have a concentration here in Roanoke, we have a concentration in Blacksburg, but we have a lot of other sites delivering care, and they are spread out all the way up to Harrisonburg, down to Tazewell, over to Bedford. So it's about 250 miles that represents Carilion's footprint. And we have different hospitals, we have primary care sites, we have family medicine, internal medicine, specialty, and we have to figure out how do you deliver that care in a more coordinated fashion. And that's been part of our challenge when we talk about this concept of population health. How do we deliver it across populations that are geographically dispersed and in many cases look very different from their demographics in addition to the geographics? So these are some of the concepts we've started to adopt. So one is called the patient-centered medical home. Another aspect of population health that we give full credit to pediatricians. Pediatricians developed this model back in the 1960s, so it goes back a good ways. And it was later in the early 2000s that internal medicine and family medicine said, hey, there's a good idea. And the concept is that we have children with chronic conditions, chronic health problems. Let's develop a team-based approach to really coordinate their care, not only when they're visiting us in the office, but between visits. We really want to make sure that we're keeping that as seamless as possible to decrease the admissions or readmissions or flares of their conditions. Makes sense, and yet that was not the norm if we go back not that far, and now it has become the norm. So that's really the approach, is this team-based, patient-centered medical approach across all of general primary care. And in addition, we adopted the triple aim that we just discussed that Dr. Berwick and the Institute for Healthcare Improvement came up with. But there's another important piece of this. We went from 3 aims and we added a 4th aim. And this has become particularly apparent in the pandemic. It has taken a toll on each of you and your colleagues and your teams. This has been the hardest period of time that I remember in my 30-year career, and it's not over yet. And we're still struggling with it. We're seeing more turnover. We're seeing more stress, more patients and families acting out, and it is harder than ever to deliver the kind of care we want to and really feel like we're energized and supported as fully as we want to be. And we have to go after that. So this 4th aim is, how do we sustain the healthcare teams doing the work? That has got to be a critical aspect of our approach. So let's go back at the patient experience. What are our patients looking for? These are just some examples. So access, can I get an appointment in a timely manner with the clinician I choose and the format that works for me? And that's changed. It used to be that it was all kind of come in the office, here's the 4 walls, this is where we provide care. Now we know we pivoted in a great way in the early part of the pandemic towards virtual. We're doing this meeting in a hybrid fashion. I don't think that's going to go away. Exactly what it's going to look like, where it's going to land, we don't know yet, but our patients are demanding choice. And we got to figure out how we can do that and not sacrifice on the other aspects of quality and cost. Centeredness, are all the members of the team working to help make the experience more helpful and less scary? It is scary. Can I go in a waiting room and feel like I'm not going to come out with an infection? You know, that's a new aspect we weren't really worried about. Maybe with flu, but certainly with BA.5 of COVID-19. Teamwork, do all the members of the team work together even across departments? This is what Don Berwick did not see in the hospital. And I think we've gotten better at it, but we still have opportunity. So going for the patient-centered medical home, how do you look at it from a system standpoint and start to put some more pieces together? And this is this concept of, what does it mean to be an accountable care organization? So how do you coordinate at an even larger level? You're looking at the hospitals, so the hospitals and post-acute care settings, the nursing homes, how do we connect and make sure we're doing that in the right fashion? How do we work with pharmacists? We know there's not enough pharmacists right now. They've had their own struggles through the pandemic, but we have to work with them and look at things like medication adherence, affordability, access for those. Specialists, can we get access to our specialists? We've developed something new called e-consult. So if we can't get you there in person, maybe there's a quick question we have. We can put that into the old curbside consult, but do it in a way that allows our specialty colleagues to be able to really review the chart, give an informed answer, and get something going within 48 hours rather than waiting a month or 2 to get your patient seen in person. PCPs are still, I think, an anchor. Our primary care approaches are critical to be able to help our patients. And then we're looking at combinations and collaborations with community-based organizations. That's more important than ever, too, is to really partner with those that are in the communities and can inform us about some of the things they're seeing on the ground and approaches they're taking to provide more resources. And even the payers. You know, we have had somewhat of an adversarial relationship with our payers, and that, I'm not going to say that's gone away, but we're looking for ways to be able to partner in some creative and collaborative new ways, and hopefully can continue figuring that out for the benefit of our patients. Just giving you this kind of flavor, we're not going to go into detail of each one of these, but an ACO has to look at all of these aspects. And so it is a comprehensive view. We're looking at what patients are we talking about. So if you're talking about you're an ACO, which patients are you trying to really work on, get information about? And that's the attribution. So which patients are part of your system, are regularly following up there, rather than they've seen you once, but maybe seeing another system more frequently. Risk capture, we're actually going to talk about that in a minute, because that's a key one to make sure you know what is the true complexity of the patient you're taking care of. Information. You have to know what kind of information is key to be able to have in a timely fashion, and looking at it from an analytical standpoint to know which patients are more likely to get sick and which need our attention more than others. Gap closure. We see that now in the lower left corner of our Epic screen. Here are the gaps, and how easy or hard is it for us to close those gaps. One that has become, I think, pretty well known in your group and in my group as well is immunizations. So I'm not talking about COVID vaccinations. I'm really talking about the bread and butter childhood immunizations. We have seen pediatric populations falling behind. How do we identify that? How do we answer their questions? How do we help them to catch up? Cost control. So I say reduction here, but it's really control. How do you control those costs, not try to add unnecessary costs when we can get to the same outcome in other ways? You have to have good contracts. So you can be doing fantastic care and not get the credit or not get the revenue if the contract doesn't match. And then compensation. How do you make sure we are compensating not only our physicians, but also our ACP partners and our staff in a way that is going to align with the work that we're asking them to do? So this is our ACO. So all of you are part of an ACO, whether you knew that or not. So you're part of an accountable care organization called Doctors Connected. When you work with Carilion, join Carilion, you're part of that group. And that allows you, as I went back to that previous slide of the macro legislation, to actually be meeting those requirements. So you're meeting the alternative payment model by being part of an ACO. We contract with the Center for Medicaid and Medicare Services on some aspects, and you'll hear about those in a minute, to be able to care for larger populations through our ACO. Got that good echo. And this is some of our journey. Again, a busy slide you can look at on your own. We're just going to highlight a couple things. So we started back in 2009. We were the first in Virginia to be recognized as the highest level of the PCMH, or patient-centered medical home model in Virginia. And then we used that model and spread it across general pediatrics, general internal medicine, and family medicine. We continue to use that approach to this day. In 2012, we became an ACO, and our first contract was in 2013 with CMS, and it was called Medicare Shared Savings Plan Track 1. And that was what we called an upside-only type contract, meaning if we did good work in providing better outcomes and controlling costs compared to a benchmark, then we would be able to potentially get some of that shared savings to fund the extra work that we were doing. And we hired, as you can see on here, 40 care coordinators initially, nurse care coordinators, to help us to bridge those episodic visits with us in the office and start to try to move a population towards better outcomes. We did well. We actually were able to show some shared savings. There was a threshold we have, so we actually didn't receive any money, but we saved the government some money, yay. And then we were able to learn enough from that experience, though, to take on some more risk. So that first one was no risk. If we didn't do it well, we didn't have to pay anything. We could just earn on the upside. We did a partnership with a group called Evolent to help us with some of the data analytics. And we joined another contract called NextGen. So NextGen model has the upside, a little bit more upside than the first one, but it also had downsides. So if you don't do well, you have to pay money back to CMS. Well, you can imagine that our top leadership, including Ms. Agee, is not real fond of paying money back to insurance companies. And we learned a lot through that process too. We did that for 5 years, and we were able to show excellent outcomes in terms of the quality scores and also a significant net in terms of shared savings. Now, it was a little rocky at first. We had earned a certain amount in the first year. We actually did have to pay back a little bit in the second year. And then the last 3 years, we did extremely well. So we learned a lot every year. And that's the journey that a lot of ACOs have been on, is it's a bit rocky and a bit of an investment and a learning curve, but then you start to get better at it. And you start to learn how to do this work in a more consistent fashion. So currently, the NextGen model was stopped. That was not one that was continued, so we had to pick another model. And we picked one that was the closest to that, called Medicare Shared Savings Plan Enhanced. So it's different than the original one, does have an upside and downside, and that's what we're in right now. And we're evaluating it. We don't think it's as good a contract as NextGen. NextGen worked really well for us. So we're doing the same work. but we probably won't get the same shared savings because of the way the contract's set up, but it's still helping us to be able to get that outcome this is for Medicare patients. And then we have a lot of other contracts you'll see in a second for all of our populations. Said risk was important, so I just want to come back to this for just a second. So when you're taking care of a complex patient, the way that insurance companies look at this, and this sounds weird, I understand this, but this is the way they look at it. They say, okay, on December 31st, at the strike of midnight, going to January 1st, your patient who had all these complexities last year that you took care of has a clean slate. They have no risk, okay? Until you start to bill in the next calendar year and tell them you've taken care of those complexities. So between general PCPs and all of our specialty care, doesn't have to be one person coding all these things, but all the codes that are present for one individual patient, that has to happen over a calendar year in order for it to be counted in the complexity for that one patient. And then you do a whole bunch of patients and you can see what's the risk score, what's the complexity of the population taken care of. The reason that's important is it sets the benchmarks. It sets the expectations for morbidity, for expectations around hospital visits, for ED visits, for costs, even for mortality. If we know it's a more risky population, there's going to be a higher mortality for that population. But they don't know it until we've actually billed for their services. Kind of a crazy system that resets every year, I know, but that's the way that this is set up right now. So we have to be able to figure out if we are capturing that on a regular basis. And the weirdness of this is if I have an adult patient who's had an amputation for peripheral vascular disease and diabetes, if I don't assess that amputation, Medicare thinks the leg grew back because they don't know they have an amputation unless I code for it. I mean, that's the silliness of this. And yet we can learn how to do this and be able to figure this out. So this is an example down the lower right, 76-year-old female who just from her age alone and gender has a certain risk that's associated with those characteristics. So it's 0.437. And I start with that because the average across all, we'll use Medicare's population for a minute, all Medicare patients is 1. So if you're higher than average risk, you're above 1. If you're lower than average risk, you're below 1. So just for her age and gender, she's 0.437. She has some social determinant aspects that she's on Medicaid, she's Medicaid eligible in addition to Medicare, so she gets another 0.151 for that. But you can see with those two alone, she's still far below average in terms of risk. Okay? So it only happens when you see her take care of and code the other things that are on the screen there, diabetes with vascular complications, vascular disease, congestive heart failure, interaction between diseases like diabetes and congestive heart failure, then all of a sudden she's well above average. She went from a 0.5 up to a 1.8. And that's some of the work that we have to do as a larger ACO. We're not asking everybody to keep these kind of things in mind. What we are doing is tracking our individual patients and saying, okay, if you've not been seen this year, or you've not had these things addressed that you did address last year, how do we make it as easy as possible for you to help us capture that complexity? All right, another example of this just in how this plays out. If you have a patient who has a lot of complexity, has a lot of flares or conditions, then they're already in a higher spend status. And we know that. We're going to recognize the people because you see them in the hospital, you see them in the ED more frequently, and our teams are going to do their great work and bring that down. That's called traditional identification or traditional risk stratification. And it's important. So an example is a 14-year-old female with sickle cell. She's had 2 inpatient admissions, 1 ED visit in the prior 12 months, but hasn't seen her PCP in the last 6 months. There's opportunity there. We're going to work on that and improve that. What's the trickier part is getting the folks on the right. So the ones who haven't been here but are just about to tip in. And that's who we're really trying to identify, and that's been some of our success, is learning better ways to identify this population, such as a 15-year-old female with asthma and bipolar disorder, no inpatient admissions the prior 12 months, but the family is in the 3rd percentile of median income, so they've got a lot of challenges around expenses. They live in a food desert. They have no easy access to nutritional food that's affordable. She has multiple medications, including an anxiety medication that's never filled. That's somebody you're getting ready to see whether she wants you to or not. And so we've got to be able to identify those patients through being on Epic for this period of time and any clues we have so that we can start to offer resources and try try to get that patient and their family engaged and lead to better outcomes. So the strategies, we've covered some of these, but just, again, we'll start with, up in the upper right, identifying these patients at highest risk. That's where we start. Then we're doing this care coordination, bridging between office visits. And that can be transitions of care if they happen to be in the hospital. We want to make sure they don't go back in the hospital. So how do we do good transitions of care, complex care management, advanced illness care? For some of our patients, they have a condition that's not going to get better. And we need to be able to help them know their choices, respect their choices, do some of that care, and sometimes that's even palliative or hospice. Address gaps in care, any gaps, we want to be able to address those, and then look for any other higher cost, higher poor outcome opportunities that we can work together as a team to take care of and move in the right direction. So how many patients are we engaged with and dealing with? So if you look at this, so we talked about the Medicare Shared Savings Program that we're in now. We have 41,000 patients, so a lot of patients in that particular program. This is a full risk contract on traditional Medicare patients. We have Medicare Advantage. So these are commercial Medicare Advantage plans. We have 21,000 patients mainly centered with Humana and United. This is upside only, so there's no downside, but you have to do the work to be able to potentially earn either quality, revenue, or shared savings. And that's particularly important if you look at a time during a pandemic when we initially had people who did not want to come see us. So if they're not wanting to come see us, they're not wanting to have, they're putting off their elective surgeries, their visits, the cost went down, but our revenue went down too. And this was in some ways almost a diversified approach as a business, as a healthcare business that has a mission to say we've got some revenue because we're actually helping to keep costs down, partly because of our good care, but during that time it was also partly because of the pandemic. Managed Medicaid, we have 56,000 patients. So this is really expanded. We had less than 10,000 if we went back to prior to 2019, and you can see it's more than, almost sixfold in terms of the number of patients that we have now on Medicaid compared to where we were before. 6 plans, no risk, but we do have upside. We have quality payments that are associated with the metrics, and you'll see those in a minute. And commercial, we have 74,000 patients on commercial. We mentioned all these. This is not the entirety of all the patients we take care of, but these are all the patients that are in a contract that has a value-based component in which we're graded on, and we have an opportunity to provide better care and a new stream of revenue to support that work. Over the past 5 years, these programs have produced a 45% return. That's actually a good thing. So it's on, it's 45% extra on top that allows us to be able to fund some of the new positions and work and money that we put into that. How do we do? There's a lot of different aspects we can look at this, but I'll just tell you in terms of controlling costs, we've actually done traditionally very well, both compared to our larger region in the Mid-Atlantic and compared to the country. So we're not a high spend organization. We are thoughtful. We're not doing extra labs, extra imaging just at the whim, just because we can. We do it because it's going to help our patients. And that's proven out as we've looked year over year on these metrics, and something I think we can be proud of. How do people contribute? I mentioned about capturing that complexity, also about the gaps in care, and of course attending to those and trying to help our patients get caught up. And then even in how we're engaging patients. And that again isn't easy. I'm coming back to, again, our patients are frustrated. They can't get in as quickly as they might like. Their patience has worn thin. And sometimes they take it out on our staff and on us. But we still want to provide them with the best experience that we can. And knowing that they're suffering from a health condition or from fear, what can we do to try to make that experience a bit better? I actually show you a little bit of money, just to show you kind of, again, we're leaving some opportunity on the table. So if you look at these opportunities, actual performance in the right-hand column, opportunity, this is 2020. Sometimes it takes us to fully wrap up the amounts to get the full numbers for you. But you can see for quality and what they call utilization. Utilization might be going to the ED when maybe they didn't have to go to the emergency room for that care. So about $2.5 million in opportunity. We got a little over 1.5. That's not bad, but it shows you that there's still opportunity. This is not about just the money. I mean, we want to make sure we have the money to do our mission, but it means that there's gaps in care or opportunities for our patients that we can continue to find better ways to do. Shared savings, about $1 million in opportunity, and we got not as much as we'd like on that. Now that's a bit of I want to make sure the audience understands this. If we are really trying to reduce their costs. That's incredibly important. We want to look for anything that is an opportunity there. But it doesn't mean we're going to be backing off on other services that we can provide on the fee-for-service traditional ways we do this as well. So we want them coming in for elective surgery. We want them coming in for things that we think are good care. These are a little bit of a dynamic tension, So if I provide more of this, there may be less shared savings. And so we have to make sure we're identifying the right parts of unnecessary or duplicative care. That's what we're really going after. And then the per member per month, we actually get some payments that help to fund some of our care coordination activity just based on the number of members we get. And we get all of that because that's actually based on the population that we serve. So quality outcomes. What about these outcomes? What are we really trying to achieve? So preventive services, well, and we need to see if we can catch up and really continue to provide those in a timely fashion. Good control of chronic conditions, so diabetes, asthma. More and more we're seeing mental health issues, depression, anxiety, flares of other conditions. Avoiding unnecessary care, ED visits, hospitalizations, readmissions. Decreasing low-value care. We have an Epic, it pops up. You just ordered a BNP last week. Are you sure you want to get another one? Sometimes the answer is yes, because I'm doing it for the future to follow up on something. But it's a good reminder in a way we can decrease duplicative care because you didn't know your colleague had ordered the same thing last week. Equity. Does everybody have an equal access to the best care? And we know the answer there. The answer is no, but if we can identify pockets of populations and individuals that have barriers, how do we start to decrease those to work to minimize them so we can improve that? And then mortality index. And what I mean by that is you can be living in a smaller geographic area, and in one part of that area, you have a higher risk of death than you do in another area. And you think, why does that? How does that make sense? Well, part of that is income, part of that is access, part of that is education, part of that's transportation. All of those things are things that we're starting to pay more attention to and see what we can do to help. So these are some of the pediatric Medicaid metrics. We're not going to look at all these. Look at the bold, but just give you some of the categories. Immunizations, pretty obvious. We want to make sure that we're giving our pediatric children, our pediatric patients an opportunity to stay immunized. And we can see what happened in New York. We have polio in this country as an outbreak. That's not something that we're really feeling great about. And we know there's some populations that have lapsed in their polio vaccinations. And that's scary. I've got a patient of mine who has been vaccine hesitant and has 2 teenagers. They're coming in 2 weeks. I wish they'd come in today, but they're coming in 2 weeks to get their first polio vaccine. And I've been talking to them for years, and it took the news in New York to get them to come in. I'll take it. Whatever nudge they need, let's get you protected. So immunizations, lead screening. Not as much of a problem as it used to be, still a problem, especially in some neighborhoods, some houses. Well care visits, well child visits, well adolescent visits, let's get them in. ADHD, so helping our children as they're coming back to a tougher school environment than ever in some ways to be able to pay attention to maximize their learning, and they have a lot of catching up to do. That has been a big toll of the pandemic. Mental illness, same thing. We've seen a lot of flares, a lot of patients, almost all of our populations have been affected by more anxiety, more depression, more mood disorders. Substance abuse, unfortunately, same thing. Alcohol and other substances. We have to be screening for that and addressing it. And then asthma is another one that you see there as well. And then some variations on different ages. Those are some of the more common ones for Medicaid that we are paying attention to, being graded on, and working to improve. Here is a commercial one. It's a little bit dated, but I used this because it was helpful in terms of a point. So this is from 2018 from Anthem, and some of the metrics are from Virginia Premier, but these 2 from Anthem at the top, and I'm going to focus on the top one in particular. So pharyngitis, now if we see somebody with congestion, a sore throat, we think COVID, but previously we thought, well, it could be some viral, pharyngitis, or it could be strep pharyngitis. And although we're not seeing quite as much of that, it's still out there. And what Anthem has in their current agreement, so it's there still today, is saying if you're going to give an antibiotic to a child for a sore throat, have you done something to be able to assess if you think it's truly strep throat? So yes, you can do a culture, maybe the gold standard or ASO titers, dating myself going back when we used to do more of those. But, have you done something? Rapid strep is the thing that they're looking for. Have you done a rapid strep? it's not even that it makes sense to do that on every patient. You might be seeing one patient and their sibling has documented strep, and they meet all the criteria or the risk, scoring. Just treat them, But on average, are you using this as part of your strategy? And how does that compare to others in the state or in the country who are doing this and trying to be more precise with their antibiotics, rather than just, it's a sore throat with Exudate, and I'm going to go ahead and throw some antibiotics at it. That's a metric. So it's the number of patients who received an antibiotic with a diagnosis of pharyngitis who have also had a bill for a rapid strep test. That's the metric, okay? You can argue the details of it, but that's the way that we're being measured. And that's one example of some of these metrics. So how can you help? Well, obviously, just be curious. We want you to be curious about your patient outcomes and ask for your data. You may be getting some data. We're still working to make it better. Dr. Keys and I have this conversation all the time with our colleagues in informatics is, thank you for the data you've given us, but here's how we want it to be even better. And that's an ongoing challenge because we have a huge system and we want to make sure that you have access to Epic and you can at least get in the record and keeping the lights on. But unless we can pull the meaningful data that's going to guide us toward better care for our patients, then it's really not getting the best out of that investment. And we've got to keep asking for that and keep really, in my opinion, demanding the best reports, the best analytics to guide our patient care. We want to look for opportunities to help your patients to get and stay caught up on preventive services. I know you're doing that, and you need data to help inform, both to the individual patient as well as maybe a list of your patients who are behind on certain things so that we can have other ways of contacting them between visits. And then also following up for their chronic conditions so they don't show up for the first time in the ED if we could avoid that. And then looking for opportunities. What else can you do that can help in this effort that is across departments? We have some of your colleagues who are on some of the committees that we are working on across all of primary care, and then sometimes primary care with specialty to figure out better ways to do this. We have a specialty council, and we have an ambulatory clinical advancement and patient safety committee that's looking at quality metrics and trying to find better ways to improve this work. So I'm going to close with this and actually have a little mini quiz. It's a 2-question quiz, so you guys are going to do great on it. But this is the Texas Tavern. How many of you are familiar with the Texas Tavern? If you've been in Roanoke, okay, so most of you have heard of it. So the Texas Tavern, small little hole-in-the-wall place that has a large reputation. And they have a sign, and this is one of their signs. It says, "We seat 1,000 people, but only 10 at a time." It's a cute little sign. In some ways, though, that's population health. And if we think about pediatric population health, you're taking care of large numbers of more than 50,000 pediatric patients in contracts that we are working on and trying to improve their health, but you're doing it one child at a time. And we never want that to stop. We want you to attend to your individual patients. We want you to be aware of there's larger work that we're doing as a system and invite you to play your part and in whatever part that may be so we can help that individual child, but also help all of our children. So here's your first question, all right? And for those that are on virtual, you're getting a little bit of a pass because I'm gonna see who can answer here in the room first because that's just a little bit easier for me in terms of seeing who can answer this one. And they're not hard, all right? So predictive analytics, that's what we talked about in trying to predict who's gonna come in. What is it? Is it the process of capturing the full risk of the patient? Is it coordinating care after hospital discharge and between visits? Is it using data to predict the risk of future utilization and cost? Is it using statistics to predict the winner of the ACC basketball tournament? Is it using artificial intelligence to aid in diagnosis? What is predictive analytics? C. Sorry. All right, C. So I'm hearing that from all of you. Good. So it's C, using data analytics on the risk assessment forms, diagnoses, labs, medications, even social determinants of health to better predict future risk, future utilization, future costs. All right. Pediatric population metric on pharyngitis. What does it measure, actually? How quickly patients with sore throats are triaged and roomed? How many patients with pharyngitis are given opioids for the pain? What percentage of patients with a diagnosis of pharyngitis who are given a prescription for an antibiotic also had a test for rapid strep? What percentage of patients with strep went on to develop complications? Or, my favorite, what percentage of pediatric residents develop sore throats from yelling, "We love what we do"? Which one is it? CE, although you want it to be E, don't you? You don't, yeah. All right, so you're right, exactly. So that's the metric. And you get down to these details of the metrics because they're very important to understand them and sometimes challenge. We have challenge metrics and sometimes seeing those change, especially if we can advocate those with other systems and push back on some of the insurers because they need to make sense for our patients and to the work that we're doing. That's what I've got for you this morning, and I'm glad to take any questions. Dr. Keys.
Thank you. I stayed because I had to hear the whole thing. So every time I hear this, I have more questions. So what struck me today was the ACO is just not one thing. It's multiple carriers, and each carrier has different aspects of their contract. So I'm thinking, okay, I'm seeing patient X right in front of me. So I just need to provide good care to that patient because I can't figure out whether they're Anthem, they're Medicaid, they're this, and their contract says X, Y, and Z. I have no way of knowing that. Is that correct?
I think you're thinking of exactly the way that I hope all of our clinicians can think of that, Don. Because that's been, we did a count. We actually counted all the different metrics that we have been dealing with across insurance companies, and it was over 300. It's over 300 metrics. You can imagine a scorecard with 300 items on it, you know? That's crazy. You cannot attend to that. And so we want what I call a non-denominational approach towards this work, meaning you don't need to care who their payer is. They can have no insurance, they can have commercial, they can have Medicaid. It should not matter. You provide the best care. What we need to do as a system and as an ACO is make it easier for us to be able to close gaps in care, do the right choice, and capture the risk. And that needs to be built into the EMR. So I'll use the example of our risk capture. Right now, we're still doing it by paper, which is crazy in these days. So we have these brightly colored piece of paper, especially for our Medicare patients, that says your patient was, evaluated for COPD last year. Make sure you evaluate them this year. Okay, check, got it, and do that. But that should be integrated. This next year, we're finally going to be achieving that. We're actually having a part of EPIC called Healthy Planet that's going to allow us to be able to track populations and have those risk aspects built into the EMR. That's overdue, and I'm looking forward to that. So it needs to be integrated behind there. We need to have smart BPAs, best practice alerts, not the ones that annoy you, but ones that remind you. And I'll use the example of reminding me that I just had a BMP last week. I actually think that's a good one. I want to know. Now, yeah, I got to click through it, and yet I may not have known because maybe somebody in the ED had ordered that. I didn't know that they had just done that one. I think that's a good reminder. But they have to be very thoughtful and designed so that they minimize interruptions and slowing down care, but actually help us to reduce costs or to improve outcomes. So I think you're exactly right. So I would not ask anybody to say, first check their insurance, and no. The day I start doing that, Don, I'm not doing this work anymore. Great question. Yes, sir.
Depending on the percentage you give me, hoping not to water down the talk because it was really enlightening. What, the number of patients in the ACOs, what percentage of our total patients might that be?
Yeah, great
question. What's the forecast?
We're about 60% of our patients are in a value-based contract. So about 60%. So that 193,000, that's about 60% of the patients that we regularly see. Now we touch base, with single visits with even larger number of patients, but that's about the number. And I think it will slowly increase. There were some predictions it would rapidly increase and that we would see more like the West Coast where you have capitation populations and all of them are in, an HMO or PPO. That's not going to happen fast. It's really not. In this part of the country, there's much more of a mix of fee-for-service and fee-for-value. And we're learning to navigate both. And I think it'll be more of a slow transition. Good question. Yes, sir.
So 2 questions. One is with this kind of structure for recommendations for assessing care, example is strep throat. You go into an urgent care. I consider nowadays a rapid strep test is considered a vital sign now. So how do we prevent overutilization based on those ACO recommendations? And the second question is equity across those who are in those ACOs and those who are not. I do think the managed care expansion was not kind to our complex care children, and because they're high RAF, they're high utilizers, they have high morbidity just inherent to their underlying diagnosis. How do we balance that out for those who, there's times we say, well, we could use that same money and care for more children than one child who has complex care.
Yeah, two great questions. I would say on the first, that's another reason I use that example, because I think strep is one of the ones we haven't fully figured out about the most cost-effective way to be addressing that. Wrapping strep on everybody or on nobody, I don't think either example makes a lot of sense. I do think that some, thoughtfulness about a risk score or, calculation, so you're not just saying, let me throw it at this and this is more likely viral. If it has the characteristics and it really looks like strep throat and it's matching, one of the things that guides us on that, I don't think you need a rapid strep on everybody. I really don't. I think that can be its own waste. But we know that throwing antibiotics at everything, and there's examples that we have in pediatrics and family medicine where, it's just easy. They're expecting an antibiotic, I'm going to give them an antibiotic. It's like, no, that's not thoughtful, approach. So I think the work is still going on with that. I don't have an answer for it, but I agree with you that we're not landed on a good approach yet. In terms of equity in our most complex patients, I actually, the examples that come to my mind are the ones where they are actually getting more resources I see now, in general, not to a person, but in general than we did, I would say, decades ago. I think we're identifying them and bridging some gaps. I think they had excellent care when they came to their specialist, they came to their primary care physician. We weren't always doing as good a job, and I'm going to pick on family medicine even more than pediatrics, because again, the concept started in the 60s, so you had a lead on us, in terms of saying, how do we do a team-based approach and follow these patients over time? But I think we're getting better for a lot of patients who fell under the radar. And so if we can continue to build on that and say, we've got the right list of patients with cystic fibrosis that we're going after, and that's one obviously that's had a lot of work for many years, but I think it's also one that we've figured out and done much better than some other populations. How can we make sure we're doing the same for patients with diabetes, patients with asthma, patients with mental health? That's one of the ones that we're still figuring out too, of, some of these aspects of anxiety and depression are becoming more chronic. Okay, so then how are we following them? How are we objectively following them with scoring systems and making sure we're getting it right? I think there's an aspect that has improved from an equity standpoint. Do we miss some people? Yes. And so are you thinking of any that we've taken resources away as we've done this work? Because I'd love to know more.
Yeah, I think with the expansion, there's access to certain just daily care for complex patients that is harder for them to achieve. And then you add to that and more recently, supply chain issues that just routine care at home is not the same. And I see some consequences of that. So.
Well, and you're right. If you're looking at that from a macro level, I think you are we spending money on this versus can we have more in the home resources or more community-based resources? That's a good point, and I wouldn't argue that. I think that's something we have to wrestle with. We're trying as as a Carilion organization to figure out how we can partner better and not be redundant with resources or leave gaps. And there's a lot of work we have to do still in that. Love to talk with you more offline and work together on that. It'd be great. Thank you. What else? Other questions? I don't know if there's any online you can tell me.
There is not a question. There is a long comment from Dr. Ward.
Okay.
It says, I would challenge the notion that physicians should not be aware of what type of insurance plan the child's family has. I experience knowing and working with family with shared decision-making is more value-based direction, quality over cost. If we navigated this without knowing the family, will face more costs when insurance company does not pay and hospital system continues to bill the family. Driving up cost for families can influence trust with the healthcare system beyond trust of the physician.
And I would say, Dr. Ward, that is very fair pushback and feedback. I don't want you to be ignorant of any challenges that your patients have. And unfortunately, a lot of those do center sometimes around insurance or not insurance, authorizations, navigating through that. So you're absolutely right. What I don't want you to do is to say, I've got to memorize every single metric of every single insurance company, and then I'm only going to do these for this particular population and do those for the others. I want us to find the best ways to do what we think is evidence-based and standard of care, and then let's figure that out. That's one reason that I work for a nonprofit. I work for a nonprofit, as you guys do, who works to find ways to bridge those gaps and has a charity care policy and says we're going to do our best to meet the needs of the patients. Are we perfect at it? No. But it is a very different approach than some who are just focused on a couple of insurance companies or just saying I'm going to really gear towards commercial rather than other governmental or non-insurance. That's the approach I don't want us to take. Well, thank you so much. Hope you have a great day. Appreciate it.